Live from Boston, my name is Emilio Madrigal, and today is July 17, 2020, and I am joined remotely by my good friend Rifat Manan, who is in Philadelphia. Today, we're happy to welcome back Dr. Daniela Allende, who is the director of the Hepatobiliary and Pancreatic Pathology Division at Cleveland Clinic. Today, she will be presenting a GI pathology talk with the title of Go with the Flow, Selected Cases of GI Vascular Pathology. As always, please feel free to write comments and questions in the Facebook and YouTube chat windows, and we'll make sure to pass those questions along to Dr. Allende at the end of the talk. So with that, I will now pass the microphone over to Dr. Allende.
Thank you, Emilio, for this introduction. Thank you for having me again. I'm going to be talking about these cases. As I mentioned before, there's some bread and butter things that we see every day, but also some challenging cases that hopefully are new to you. So the first case is from an autopsy on an older male. This is a section from the esophagus. And as you can see at low magnification, the outer layers of the esophagus are intact, in this case, the adventitia and the muscle. But as we get closer to the mucosal lining, which would have been squamous to glandular in this case, because it's the distal esophagus, that is totally replaced by this inflammatory infiltrate that is band-like and has neutrophils. And admixed with the neutrophils are basically this pigment deposition that is golden and finely granular. At places, you can see how the mucosa is totally gone, but the infiltrate reaches the muscularis propria. In this case, it's still quite superficial. The submucosa is still intact, but in some cases of this entity, this necrosis will reach actually deep into the muscularis. So I think you could see it, but this is actually a case of black esophagus. This is a not very common entity. It's called acute esophageal necrosis due to ischemia as an underlying mechanism, but also superimposed direct injury and also decreased reparative mechanisms, because these patients tend to be actually tend to have comorbidities. Patients tend to present with bleeding as well as dysphagia and abdominal pain, and they can go into a rapid down spiral and really collapse. The characteristic view is this one that we are seeing here from the autopsy. This slide actually was shared by a good colleague from Estonia. The black discoloration of the mucosa on this is the characteristic view. It starts distally and progresses proximally. Brings up other things in the differential, obviously, but this is quite characteristic. These patients tend to have a high rate of complications, including perforation and mediastinitis, for which the mortality rate is really high. Histologically, it's exactly what I just showed you. In this case, it goes a little deeper. Actually, it's involving probably in part the submucosa. The pigment, although some people may think is kind of reminiscent of iron, it doesn't stain with any iron stains. And it may be weakly positive on PASD, for which is thought to be like lipofuscin. And it's going to be admixed with that infiltrate. I think this case is actually in the discussion of esophageal bleeding. We see other things in this differential much more commonly as gastroesophageal reflux disease, infections, NSAIDs, and so many others. So this is actually a very rare form of esophageal bleeding, but I felt it's something that you may have not seen. More commonly, we're going to see active esophagitis, particularly when they get very ulcerated and particularly deep. Remember, for those in training, GMS can highlight the organisms, particularly in the more subtle cases in which you may see only a little bit of parakeratosis and scar on neutrophils. The other common infection that leads to ulcer and bleeding of the esophagus is actually herpes simplex virus, the classic intranuclear inclusion, margination of the chromatin, and even multinucleation in some of the cells. This obviously can be highlighted by the immunohistochemistry if you have it available, although if you have this type of picture, it's quite characteristic and you don't need to use it. Bile esophagitis is something else that we see very commonly and could lead to macroscopic or microscopic bleeding. In general, it's microscopic because it's more of a cause of pain than bleeding. But you can see areas of hyperplastic changes in the mucosa with parakeratosis. And in the floating debris that you see in these patients with ulceration are mixed with the neutrophils and fibrin. You will see the refractile material of the pill. Sometimes you even see pigment consistent with iron in patients taking oral iron pills. The other thing that we sometimes see in these ulcers, in this case was a more distal ulcer at the gastroesophageal junction with evidence of bleeding in a patient that was in the ICU and he was taking previously caoxalate for hyperkalemia. Is these crystals in the lumen? Here is obviously the ulcer bed. In the floating material, we're going to see these basophilic crystals that have fish scales characteristic of caoxalate. So this is supposed to be something superimposed, not necessarily responsible for the injury, but something that we can recognize histologically. Okay, let's go back to the slides. We're going to share case number 2 here, which is this one. Okay, so this one was a gastric biopsy. As you can see, a low magnification. We have several pieces. The pattern here, I would say, looks more pink than blue in the lamina propria. I always try to use pink and blue for the residents in training. I think it's helpful for them to identify what is pink and what is blue. In this case, the blue happens to be more along the lines of the epithelium, and that's because of this reactive mucin loss. Some corkscrewing focally in some of the pieces, but the lamina propria looks more pink than blue. In fact, if we get really close, there may be some dilated capillaries that are congested. The subepithelial area looks a little bit more pale at places, and a lot of these little capillaries that are congested right there. So this can be a very subtle and sometimes non-specific picture. Obviously brings up the differential diagnosis of reactive gastropathy. But let me show you a couple of things that I think that is special about this case. When these patients sometimes present with gastric bleeding, obviously they have abdominal pain. The differential is quite broad because Helicobacter pylori also can cause ulcers sometimes, so it will be in this differential as well as chemical gastropathy, stress ulcers in patients in the ICU. Other things that can cause bleeding are less common, like de la Foix lesion. These are very large arterioles that get eroded and bleed eventually. Cameron ulcers, which happen in patients with hiatal hernia due to mechanical compression. And then a group of diseases that occur sometimes in patients with cirrhosis and portal hypertension and other diseases in the setting of other diseases like portal hypertension gastropathy and gastric antral vascular ectasia. The case that I just showed you was a case of gastric antral vascular ectasia. And I know that because I will show you a few things about this case that were characteristic. Our case was much more subtle. It didn't have the well-formed thrombi that we see in this case. These patients tend to have association with autoimmune disorders, which in this case the patient had. They are more frequently women. They present as a reactive gastropathy from the low power. They tend to be, for that purpose, they tend to be not very inflaming the lamina propria, and the lamina propria tends to have edema and fibrosis, as well as these dilated and congested capillaries with thrombosis. In that case, we did a CD61 that revealed this thrombi, which is a key feature of this entity. It's very helpful, I would say, not in these type of cases that we already see the thrombi on the H&E. Here I don't need the CD61, but in the cases of less obvious thrombosis, the CD61 can be a very very useful tool that is sensitive and specific. As you may know, CD61 is a marker of platelets and megakaryocytes, so it's quite useful in this particular setting where thrombosis is not obvious. Our patient also had the characteristic endoscopic image of a watermelon stomach with longitudinal stripes. As opposed to the main differential diagnosis, there is portal hypertensive gastropathy. Patients with portal hypertensive gastropathy present endoscopically with this erythematous view that is in a mosaic fashion or a snake skin. So if you have the endoscopic image in the histologic findings, you can make the diagnosis, but it's obviously a clinical pathologic correlation. And there's a subset of cases that fall in between of this spectrum that may be more challenging, in which the C61 can be helpful. Histologically, these cases of portal hypertensive gastropathy look very similar, as I said. In this case, as you can already tell, this is oxyntic type mucosa, which is a clue, as patients with GAVE tend to present in the antrum. Here you can see the subepithelial changes in the submucosa with myxoid changes or even edematous, sometimes, like in this case, changes, congested capillaries, and reactive mucin loss. As I point out here, there's not really any specific feature, but it's more the clinical pathologic correlation. Since that in this differential diagnosis, I can also cause bleeding, and a similar picture are iron pill gastropathy. In the case, obviously, it's a reactive gastropathy with marked reactive mucin loss and extravasated blood in the lamina propria. The pigment can be obvious, but also subtle. And if you do an iron stain, it will highlight the pigment in blue for you. If you have any questions, this is a nice study from the 90s from Dr. Abraham on how these deposits can be pretty chunky and crystalline. So sometimes you are able to see this in the superficial ulcer, aspect of the ulcer. So you don't necessarily need the stain, but it's useful. Some cases get to be really quite prominent, and in this case, actually, the superficial aspect of the mucosa is necrotic. And you can see how, because of the necrosis, the quality of the granular quality of the iron is less obvious. And in that case, if you do an iron stain, it will pick it up and help you in the diagnosis. So this is a quick and dirty comparison of these entities that we see more commonly. Obviously, the reactive gastropathy associated with medications, salivary reflux, among others. And it's a disease that predominantly occurs in the antral mucosa, right? GAVE has a similar morphologic appearance, but it also has some distinct features, as the association with immunologic disorders, more frequently in females for that matter, and the characteristic evidence of vascular ectasia and thrombosis that can be highlighted on CD61. The main differential, as I say, is portal hypertensive gastropathy that is more commonly seen in male. It can present in children. There's a strong association with cirrhosis. I have to say that GAVE can happen in cirrhosis too, so that's where the overlap occurs. But this one obviously is associated with cirrhosis and portal hypertension. But look at this, location is actually helpful here. Portal hypertensive gastropathy is gonna be of the oxyntic mucosa. And even though we see vascular ectasia, thrombosis is not present. Okay, let's go to number 3. Number 3, here. So this was a patient that presented with an acute abdomen. It's a small bowel resection. As you can see, this is a full thickness view. You can see some of the mucosa more intact there, and something happening in the center. There was serosal adhesions were seen on the gross examination, and clinically the patient had a picture of volvulus. So it's not difficult to recognize, and particularly with the topic that we are sharing today, that this looks ischemic. Most of the ischemic cases are gonna be very pink and red from the low power. It seems like an oversimplification, but I want to make sure that I emphasize this because it's actually that low power impression is pretty key. And you are going to see some mimickers also today that I'm going to share with you that look a little bit more blue because they're a little bit more inflamed sometimes. So this is a pretty classic case of ischemia. You can see that there's obviously congestion and some hemorrhagic changes in the serosal layer, but the main findings in this case are actually mucosal based. We're going to get closer in a second, but I want to show you how the transition here happens very abruptly from the areas of more preserved mucosa to the areas of food sickness, mucosal necrosis. The mucosa is completely gone, replaced by inflammatory infiltrate and areas of hemorrhagic changes and fibrin deposition. If you happen to get a biopsy from this area, as sometimes happen, they biopsy the edge of the ulcer in these patients, particularly when the ulcers are smaller and the patient may be going for an endoscopy. So this is an acute abdomen. They're not going to biopsy this patient, but in cases the symptoms are not so severe and there may be very tiny ulcers, if they biopsy the edge, you may not see characteristic features of ischemia here. This is very acute, so there's not enough time to develop the classic features, but it rather looks more inflammatory sometimes. As it goes into the necrosis, you can see the fibrin, and in other areas, you can see how this was actually the villiform architecture, but now completely necrotic and gone and replaced by fibrin and hemorrhagic changes. Other areas of non-specific ulcer. So this is a classic case of ischemic enteritis. Even in these areas of necrosis, where basically you have no viable tissue on the surface, some of the deeper crypts remain a little bit viable still. So this is pretty classic of ischemia. If you think about it, the oxygen that goes into the bowel comes from the mesentery, so it goes in this direction. So the areas that are more distal will be the distal tips, and those are the ones that are going to have the lowest level of oxygen and the ones that are going to die first in an event of ischemia or low oxygenation. So that's why the mucosa dies in that particular fashion. Let me show you a few slides on this as well to discuss some of the things that we see in these cases. So we're going to discuss basically ischemic injury, more of the acute initially. So endoscopically, these patients present with erythema in the mucosa that can be quite pronounced. Remember that most cases of ischemia are segmental in the segment of the vessel that is actually being compromised. But some cases can become very striking with ulceration and pseudomembranes, which is also possible, although not that common. As we discussed in my previous talk on non-IBD colitis, ischemia can be due to multiple different things, including alterations on the flow, thrombosis and emboli, mechanical issues, like in this case was volvulus, sometimes drugs, patients on prothrombotic drugs or cocaine, for example. Vasculitis or even infections can show up as ischemic type pattern of injury. So I want to highlight this because we need to think about these things when we are sending out the specimen. It's easy to say ischemic colitis next case, but we need to be able to chase the underlying etiology. Not everything is ischemic. Things can be also show up as ischemic, but actually not because there's a reduced oxygen or flow, but mainly because there's bleeding, reducing the flow to the bowel. So as you can see, many of these things are quite common, particularly diverticular disease, ulcerative colitis, angiodysplasias, diverticular disease, the macrodiverticulum can show up this way. So there are many different entities, some of which are quite common and some are less common, that can cause bleeding and ischemic pattern of injury as well. The characteristic view is this one, which you are more probably familiar with, which is the well-developed ischemic changes. The wither crypts, these very small atrophic crypts with reactive mucin loss. In an lamina propria that is pretty hyalonized and hemorrhagic. This alternates with areas that are more preserved many times. There's a sloughing of the surface frequently. We don't have to go through this table entirely, but I want to point out that when we're dealing with arterial ischemia in particular, we can actually identify well-characterized phases of ischemia in terms of acute findings, subacute findings, and chronic findings. The acute findings are relatively straightforward and well-known, which are basically the wither crypts, the early hyalinization of the lamina propria or edema, and obviously reactive mucin loss and extravasation of blood and thrombi. The chronic phase can be challenging because it overlaps with so many things. It's basically chronic mucosal injury, and also fibrosis, and also inflammatory polyps and inflammation and stricture. So it's a less obvious picture and brings up a very broad differential diagnosis. The subacute is sometimes the healing phase, and it has also reparative changes as well as more developed hyalinization of the lamina propria and inflammatory pseudopolyps. So let's look at some pictures to demonstrate these phases and how they happen in real life. So this is very early ischemia. In this case, you can see how there's congestion and some lamina propria edema. The epithelium may be getting detached a little bit, but it's not so injured, although there's a little bit of reactive mucin loss. In these cases, you can see that there's a little bit of neutrophilic injury here. So these cases many times show up histologically as a focal active colitis, which is okay. Ischemia is in the differential of focal active colitis. As the disease develops, the hemorrhagic changes and edema and extravasation of the red blood cells becomes more obvious, as well as the sloughing of the epithelium and reactive mucin loss. This is a more characteristic case with hyalinization of the lamina propria and the wither crypts that we just mentioned. So this is pretty characteristic. As the disease develops and is more long-standing, we have more classic features of hyalinization of the lamina propria with ulceration of the surface. Again, here, remember that these cases may have these more intact crypts at the bottom, while the surface is quite necrotic. Despite the amount of necrosis, you can see that it still looks more pink than blue. There's not a lot of inflammation in many of these cases of ischemia. Full thickness necrosis develops in some cases. You can see there's significant congestion of the capillaries as well as thrombi that can be identified in capillaries adjacent and even farther away. Here is a little bit more of the same. More advanced disease with transmural hemorrhagic changes, full thickness necrosis, and these ghost cells basically that are completely sloughed off from the epithelium and nothing is left pretty much. Remember that ischemia can look like C. diff many times and have these pseudomembranes. I show you an endoscopic view of that, and it really could be a great mimicker of C. diff infection. Sometimes we see more apoptosis and a little bit more cytologic atypia with increased NC ratios and some prominent nucleoli, more hyperchromasia. So be aware that ischemia can regenerate and look a little bit more atypical. However, this tends to be a very diffuse finding as opposed to true dysplasia, which would have that sharp transition to normal. And this is obviously in the context of ischemia in other areas. It's easy to say that this is just reparative atypia. Regenerative changes can occur as the mucosa begins to heal. You can see how the epithelium doesn't look like classic intestinal epithelium, but it's still columnar with more dense columnar epithelium. And as the areas of mucosal ulceration heal, they may develop some submucosal fibrosis. I want to make sure that we pay attention to the vasculature in these cases. I always go back and sample if these mesenteric vessels have not been sampled, or I sample sometimes areas a little bit away from the ulcer. Those vessels will look like. And you can see in some this evidence of vasculitis. I have to say that in this case, I'm pretty convinced it was a vasculitis because you can see the fibrinoid necrosis and the characterized and the neutrophilic infiltrate, but in an area that was a little bit away from the ulcer and more of the intact mucosa. So you want to be away of the areas of direct ulceration. Look for amyloid in the small capillaries or arterioles, but also sometimes shows up as globular deposits in the lamina propria. Congo red stain is a really good stain to do if you are in doubt that this is amyloid. Acute radiation, rare, very rare, but can cause bleeding. And C. diff, obviously, as I mentioned before, is a big mimicker of ischemia, and we have to keep that in mind. Typically, these pseudomembranes, volcano-shaped, condensations of fibrin and neutrophilic infiltrates are going to be very prominent. When we look at the mucosa, actually the mucosa looks more blue, it's very inflamed, there's reactive mucin loss, obviously, and there may be some hemorrhagic changes, but the inflammation predominates with these cryptitis and crypt abscesses. This is a study that I already shared, but I want to quickly mention that there's a lot of overlap between ischemia and C. diff infection, endoscopically and histologically. But something to keep in mind is ischemia tends to be a localized process, and pseudomembranes are more commonly seen in the setting of C. diff. Histologically, ischemia is characterized by hyalinized lamina propria, which is a characteristic finding, as well as the atrophic crypts and hemorrhagic changes and full thickness necrosis. So applying those histologic features many times help us differentiate these two. This is a study by Dr. Patil. She's to be a colleague of mine, and they look at this series of cases, and they were able to actually differentiate, for the most part, these two entities on histologic grounds. They also tested paraffin-embedded blocks for PCR to differentiate ischemia from C. diff. However, that had very limited use. The sensitivity is very low, so stool samples or stool testing continues to be the gold standard for the diagnosis. Case number 4. Let's go to case number 4. Okay. This is case number 4. This is bowel resection. You can see fold thickness seems to be okay on the outer layers. The main findings are on the mucosa again. Another case that may come out, and then you see basically the mucosa is gone. It looks like granulation tissue. Just as of interest, there are some crystals in the lumen in these fibrinopurulent membranes. But the mucosa, as you can see, and I go by, the entire fragment is pretty much gone. I can't see any particular residual epithelial lining or gland anymore. Once we get closer here, we can appreciate that there's granulation tissue with smaller capillaries and inflammatory cells, as well as some of these bigger cells that are quite characteristic. So if you see these in this granulation tissue, these are actually CMV infected cells, which can be stromal or endothelial cells more commonly. Sometimes CMV will infect the epithelium. So this is in the differential, obviously, something to consider when we see these quite non-specific ulcers sometimes. This was a case of CMV colitis. The characteristic intranuclear or sometimes cytoplasmic inclusions are helpful. However, this is probably the most striking case I ever seen. Many times you see granulation tissue and these are not prominent, so it's kind of hard to find them. The CMV immunohistochemical stain is obviously helpful. In this case, it wasn't necessary, but it can really highlight the cases that have rare infection. Remember that when we see CMV in the bowel, like in this case, it presents like acute abdomen. The patient was bleeding. They resected the segment. It's all ulcerated. It mimics really ischemia. And it happens in the setting of reactivation, as most people have exposed to the disease in their lifetime in an asymptomatic fashion during the primary infection, except for immunosuppressed patients. So when we see it in the bowel, it's in the setting of reactivation, and the virus will infect the endothelial cells, leading to vasculitis and ulcer. In this case, there were also these crystals. If you saw them when I was highlighting them, the bile acid sequestrant crystals are fairly common in our population of severely ill patients. They are used to treat hypercholesterolemia, among other things, and they cannot be distinguished from each other because they have this similar quality of eosinophilic and non-fish scales. And they are fine. They are an incidental finding just for fun. In the interest of time, I'm going to skip this because I shared it in the previous lecture. But this is a nice article on how to differentiate these crystals from each other, and basically the ones that we are looking at is in this category. Case number 5. This one. Okay. This was a patient with history of, it's a relatively recent case. It's a history of rheumatoid arthritis and on chronic NSAID use, presented with chronic abdominal pain and symptoms of bowel, and the patient ended up getting a resection of the small bowel. As you can see, there's biliform mucosa. Again, the outer layers seem to be okay, but there's something going on here that is quite characteristic of this disease and can be grossly recognized, which is this protrusion of the mucosa and submucosa into the lumen, almost a septation, basically. When you get to the surface, you can see how many of these cases, because of the trauma, they may have superimposed prolapse type changes, as well as granulation tissue due to superficial erosion, sometimes some chronic mucosal injury. Because of that, there's some fibrosis of the submucosa, disorganization of the muscularis mucosae, and even sometimes due to trauma, you may see some arterialized small veins or even small collapse capillaries here. This actually was one of the best cases I've seen of diaphragm disease. This is another case that I used to show, which is a much more developed case with more fibrosis and muscularization of the submucosa, some architectural abnormality on the surface. These patients tend to present with GI bleeding and sometimes obstructive symptoms, like in our case. Although these diaphragms can be multiple, the disease tend to be focal, and there's a clear association with NSAIDs. As opposed to Crohn's disease, there's no far happening, and I think the clinical history is quite key to make the right diagnosis. And this is the case that I just showed. I just want to point out that sometimes these vessels can be a little bit prominent, and if you don't know the right history, sometimes we start thinking, particularly in these less developed cases with less fibrosis and more prominent vasculature, of a primary vascular lesion occurring here. So putting together the clinical history with the histology findings and appropriate sampling, I think is key. This case leads us to the discussion of chronic ischemic injury. As I mentioned before, there's an acute phase that we discussed. Now we're going to talk a little bit more about the chronic phase of ischemia. And chronic ischemia, as I said, is less defined in terms of the features that it shows, because they are much more non-specific and bring up a broader differential diagnosis. Chronic mucosal injury with branching, metaplastic changes, pyloric gland metaplasia, or left-sided Paneth cell metaplasia, basal lymphoplasmocytosis. All these changes can be seen in patients with chronic ischemia. Sometimes it's even chronic active because the patients may develop an ulcer. So it's pretty classic. So as we discussed in my previous talk, this is in the differential of acute versus chronic, but here we are in the portion of chronic right now, in which you may have acute neutrophilic injury, but clearly some of these cases are going to have creep distortion, typically less pronounced plasmocytosis, basal lymphoplasmocytosis than in IBD cases, but you may see some, and metaplastic changes for sure can be present. So As I have highlighted before, ischemia is in that differential of chronic or chronic active colitis, so we have to keep that in mind and think about the other things that show up in the differential diagnosis. This is a case of chronic ischemic injury of the small bowel. This is a terminal ileum of a patient that was having symptoms on the biopsy, and you can see how there's architectural distortion with some funniness of this small bowel villi, but there's also some pathology metaplasia, some crypt dropout. So a good example of chronic ischemia showing up in the bowel. This is a more developed case. There was probably an area of fibrosis before of ulceration that healed with fibrosis and disorganized muscularis propria. Even some prolapse changes, but chronic mucosal injury with pylori gland metaplasia in this case. As you can see, the ulcer can be quite deep and eventually heals with some fibrosis. There's some residual ulcer in this case. You may be thinking at this point, there's a lot of resemblance of what Crohn's disease may look like, and I can say absolutely, this is another case of ischemia with transmural fibrosis, full thickness necrosis, and ulcer, as you can see on the surface, inflammation that can go really deep. And this typically occurs in patients that develop pretty bad ischemia that is chronic, but also it becomes stenotic. Like in this case, there's the mucosa and submucosa are gone, the muscle is already thickened, there's transmural inflammation, really mimicking a Crohn's case. So key to the diagnosis is actually the history. The differential diagnosis, as I mentioned before, of chronic ischemia will include radiation. In this case, the characteristic, this is a beautiful example of radiation injury with the hyalinization of the vessels with foamy macrophages and obliteration. As you can see, there may be some atypical cells in the stroma as well. From the low power, it's similar to the case that I just showed you, right? With ulcer that reaches deep into the muscle, there's some mucosal fibrosis. Here are the vessels that I was showing you before to prove that this is actually the same case. But, from the low power, if we don't pay attention to those little details, it may be really mimicking ischemia and other things. Chronic radiation will also have strictures, fistulas, ulcers, mimicking ischemic injury and Crohn's disease too. The key is to find these typical vessels, sometimes the atypical fibroblasts and endothelial cells, and obviously the history of radiation. Mucosal prolapse, I don't want to forget to mention because it's a fairly common disease with in which the mucosa, the lamina propria will exhibit these bundles of smooth muscle and mild inflammation in general, but it can get ulcerated and bleed, so it can be mass forming, so it can really show up in these cases as well as part of the differential. We're getting into the more specific things that we're going to see today. This is case number 6 for the presentation, and it was a small bowel. We're going to flip it. It's a small bowel resection, as you can see, and I tried to take a section of the area that was a little bit more intact to show these features. As you can see, there is a little bit of congestion in the serosal surface of congested capillaries, but the main striking feature here, and I want you to pay attention because it's not very easy to see sometimes. I can tell you grossly, sometimes you go and you look at the specimen and this is not very obvious, but many of these patients come with a clinical presumption of this diagnosis. So we search very hard, although after the specimen is out from the OR, it's kind of hard to see. You are looking for areas of erythema or hemorrhagic changes in the mucosa or wall. But the striking feature here is obviously these abnormal vessels that are quite dilated and filled with blood in the submucosa. If you get really close, you're going to see that some of these actually reach the mucosal surface as well. In this case, there's no evidence of thrombosis, and there's very little inflammation in general unless the disease bled into the lumen and there's some ulceration. So let me show you one more thing before actually. I think I have another case that could be useful to finish this one. For comparison, we have this other case. It's actually a resection of the colon. There's classic, so if I just stay here, you can say, well, that's classic ischemia basically with all the features that we just described. This is classic ischemic injury. However, the ischemia in this case was due to something happening here that we were able to sample and show that was this abnormal collection of venules and arterioles in the serosal, more the subepithelial, subserosal fat, which is the characteristic location. So looking for the etiologies is quite important because in this case we were able to say what was causing the ischemia in that particular patient. So these two entities can be, sometimes difficult to sample and to demonstrate histologically. They require us paying attention to the growth and sampling extensively and also correlating with the clinical history. The first example that I show you is a case of angiodysplasia. These patients actually are older patients and it's an acquired lesion, so it's not a true malformation, and it's a cluster of dilated venules basically. Location predominantly are located in the right colon with another group of patients that will show up in the small bowel as in our case. And it's a submucosal to mucosal based lesion. On the other hand, arteriovenous malformation, which is the second example that I show, these lesions are present at birth. It's an abnormal communication of veins and arteries, so you're going to see a combination of both, like you see in this case, and you could appreciate in the case that I just showed you. Location is different also. Sigmoid colon and rectum are the more common location. And by definition, these are actually external to the muscularis propria, so they are actually sitting in the outer portion of the bowel in the subserosal surface many times. Case number 7 is a really good case that I find this set of entities quite challenging sometimes. So let's look at a few examples together. In this case, in the interest of time, I'm not showing you the bowel wall, but the bowel wall looks ischemic. So part of our grossing protocol is to include sections of the mesenteric vessels, which I think is key in any case of ischemia to demonstrate if there is or there isn't vascular pathology, primarily of mesenteric vessels. So you want to sample that area appropriately. In this case, when we look at the mesenteric vessels, they look quite abnormal. And I'm going to show you in a second a normal section, but in this case, you can see how the artery, this is the artery, and this is a vein, they look quite thickened. There's other layer of small muscle fibers that are pretty thick, like wrapping around and basically compressing the lumen. This is a lumen that is quite compressed. This is a vein. And there's this, what's called a collarette of small muscle fibers wrapping around and obstructing the lumen. As you can see from the low power, there's no evidence of inflammation. So this is not a vasculitis in the sense of being inflammatory. There's no necrosis. There's really primarily obliteration and this small muscle proliferation that is concentric and eccentric of the wall and obliterating the lumen. This actually is a specific entity that is called mesenteric arteriovenous dysplasia or vasculopathy. This is a picture from this paper. This is an article that was published in 2016 by Dr. Patil also. You can see how the arteries are partially obliterated, but they have the rim of a small muscle fiber around them. The lumen here is kind of hard to see in the vein. It's kind of a little highlighted in the MOVAT stain here, but clearly thickened wall. So by definition, you have to find 2 or more foci of these concentric, eccentric, small muscle collarettes around the tunica media of arteries and veins in these mesenteric vessels. Some other changes have been described, but this is actually the key finding. These patients present in two big forms, Crohn's-like presentation, symptoms-wise, and ischemic-like presentation. So they come up obviously as ischemia to the clinical presentation with chronic abdominal pain, and they tend to be all middle-aged to older women. Based on the histologic findings alone, the main differential diagnosis is mesenteric fibromuscular dysplasia. Fibromuscular dysplasia is a disease that can occur in other arteries, like coronary arteries and renal arteries as well. But it tends to be presenting in younger patients. There's a big overlap histologically, but also clinically. However, fibromuscular dysplasia tends to be more of an acute disease when it shows up in the mesentery. As I mentioned, it can occur in other vessels, so it's multi-vessel or could be in other locations, while this mesenteric arteriovenous dysplasia is not occurring in other vessels, seems to be limited to the mesentery. These are smaller vessels, so we're going to see them in the resection of the bowel, where we may not see these changes very well developed. This one will affect also the veins, while fibromuscular dysplasia is also is primarily an arterial lesion. And because it affects vessels that are a little bit larger, it generates sometimes this picture of a string of beads with stenosis and dilatations or even aneurysms that can be captured on imaging studies. While mesenteric arteriovenous dysplasia or vasculopathy is not typically seen in imaging studies because it's smaller vessels involved. The good news is surgical resection is curative of these patients, so it's a good option for them. The main differential diagnosis is idiopathic myointimal hyperplasia of mesenteric veins. This is a normal, I promise you, a normal picture. This is a very thin vein, as you can see, on the artery next to it. And this is a case of idiopathic myointimal hyperplasia with thickening of the vein. Here is, you can see that this is the intact artery and the vein that is thickened. This entity was first described by Dr. Hyde in the 90s. Here I'm showing you a MOVAT stain to highlight which one is the artery and which one is the vein, which is quite helpful. There's a lot of discussion of what this could be due to, but nothing that has been proven to be the cause. It's more commonly seen in male, older, rectosigmoid in location, and it's a non-inflammatory process that affects veins and spares the arteries, as opposed to the previous entity that affects also the arteries. This is a more recent paper from Cornell, actually showing similar pictures to what I just showed you. These patients tend to fall into this differential of IBD versus ischemia. However, again, surgery is curative because it's segmental. This is a picture from this paper from Cornell showing the quite stenotic wall, lumen with thickened wall and features that may mimic, Crohn's disease potentially. In that article, they highlighted some mucosal findings that we see in these patients. This variety of eosinophilic thrombi that are seen in the mucosal of patients that basically on resection specimens, but it can also be on mucosal biopsies. Much more bright and eosinophilic than what is typically seen in plain fibrin. The arterialized capillaries and also the subendothelial hyaline depositions, which are useful features if you are just dealing with mucosal biopsies. They compare their cases to the main differential diagnosis, and as you can see, there are mucosal features that the mucosal features that they identify were sensitive and specific to this diagnosis. The last case that I have is this one. So this one was a bowel resection. Here it looks blue. I think this one it was bleeding, and the patient actually presented with acute abdomen. But after a history of some chronic findings, and they resected the segment, as you can see, it looks fairly blue. The mucosa is pretty much gone, there's a little bit of mucosal lining here, but the rest is ulceration and this really deep blue infiltrates. When we pay attention to what is going on, you can see that the arteries are quite okay. Most of the infiltrate is around the veins. The infiltrate is actually a combination of lymphocytes and plasma cells, but also some multinucleated giant cells. And if you go through the specimen, there are different. You can see how the lymphocytes are actually infiltrating the vein wall here. So it's really a lymphocytic phlebitis in this case. The veins can become obliterated, and in some of the veins is more of a granulomatous type of infiltrate. So recognizing what is happening, what vessels are involved, what type of infiltrate do you have is key. Let me show you a few slides on this entity. This was a case of enterocolic lymphocytic phlebitis. Some people think that this is within the spectrum of the previous entity that we discussed, as this one being the more burnout phase and enterocolic phlebitis being more the active phase. However, I don't think there's clear evidence for that yet. This entity tends to present in the right colon and terminal ileum, and again, it's a localized process that occurs in older patients. Because it's segmental and is localized to that segment, once this is resected, the patients do fine. There's no systemic disease. And there has been a strong association with certain things like hypertension, cardiovascular disease, in particular some drugs. And there are a few papers associating this entity with lymphocytic colitis as well. Like in our case, the disease can be more lymphocytic, but sometimes more granulomatous, and there's evidence of fibrinoid necrosis in this particular vein. Remember, the arteries are spared in this entity. So this is a quick and dirty comparison of these vascular processes that can occur in the mesentery. I just want to point out that even though there seem to be a lot of overlap in some of these findings, some key distinct features are helpful. For example, the inflammatory nature of enterocolic phlebitis, the location for the idiopathic myointimal hyperplasia of mesenteric veins, and the gender predilection of in men. The mesenteric arteriovenous dysplasia is typically a female disease that will also involve not only veins but also arteries. The one new entity that I lumped here was idiopathic mesenteric phlegosclerosis. This is very rare. There's no clear gender predilection. It's a disease of older patients that affects the vein. And basically, there's mural thickening and calcifications of the veins. I think you can appreciate a little bit, even in this small picture, a little bit of calcification. I put it here for completion. So we're going to summarize this as some practical points. GI vascular disease can not only be ischemic, but also due to bleeding. So it may show up in different ways clinically. Correlation with the clinical history and appropriate growthing, inspection, and sampling are key to the diagnosis. Ischemic injury has a wide range of morphologic features and a very broad differential diagnosis that we always have to keep in mind. I always highlight that it's important to look beyond ischemic changes. It's easy to say many times ischemic colitis, ischemic enteritis, next case, but look for an etiology. Also assess the margin involvement, particularly when it's beyond the mucosa, can predict a high rate of complications afterwards. And now to end, I have a few questions to see if you were paying attention. So let's go with the first one. If we have a female predominance in this entity, antral location, the watermelon stomach on endoscopy, and thrombi in mucosal capillaries that are C61 positive. These features are characteristic of which one of the following: portal hypertensive gastropathy, reactive gastropathy, H. pylori infection, or gastric antral vascular ectasia. So I'm going to give you a second to think about this, and I want to Okay.
Looking at the responses, so I will let you know quickly as I see.
Okay. I'm gonna give you a hint. It's not this one, and I think you can guess that one. That one is not the one.
I think there are more people who are going for gastric antral vascular ectasia.
Yes, I love it. We got that one right. So that's a pretty characteristic description of GAVE. Next question. Which one is not true regarding angiodysplasia? So we're going with which one is the incorrect option. Is it an acquired lesion? Is it present at birth? Is it a mucosal, submucosal based lesion? Or is it the right colon is the most common location? So which one do you guys think is wrong for angiodysplasia?
And we will wait a few seconds so that
Yes.
get some options. I think there are mixed options. There is acquired lesion. Some people are trying. More are in favor of acquired lesion is not true. Yeah, and there are also some others opting for B, that is present at birth.
All right, those opting for B are right. As I mentioned, angiodysplasia is actually acquired, so it's more common in older patients when arteriovenous malformation is the one that is present at birth. Last question. Enterocolic phlebitis is characterized by small muscle collarettes around the tunica media in arteries and veins, involvement of arteries, lymphocytic phlebitis, occasionally necrotizing or granulomatous phlebitis, or is it a systemic disease and involves other organs? So which one is correct?
We will wait a few minutes and see. You see, there are options for C, that is lymphocytic phlebitis. Yeah, there are more for C.
All right, you guys got it right. Obviously, this is not right. This is actually the description of mesenteric arteriovenous dysplasia. Because it's a phlebitis, we mentioned that the arteries are spared and is segmental, so there's no systemic involvement of enterocolic phlebitis. So this is the classic description for this entity. And with that, I finished. We went a little bit over, but I hope you guys enjoy it, and I'm happy to take any questions.
Oh, yeah, thank you, Dr. Allende, for covering this very perplexing topic on GI pathology. So one question that I see online is, this is from Nabanita, that how can you please explain how to properly sample mesenteric vessels? Because as she said that they are not doing it.
A really good question. Sampling, I would say sampling in general. We tend to sample areas of when we first we examine the specimen grossly. We look at for any serosal evidence of hemorrhagic changes or fibrin because there may be an area of perforation. So you want to start by looking at the specimen from the serosal surface. We sample the margins. We open up the specimen and we look at the mucosal surface. We look at for areas of hemorrhagic changes, erythema, mass-forming lesion, ulcers. We sample that. We also sample the normal areas of the bowel as well. But when we look at the mesentery, I think it's important to look at the mesentery adjacent to these areas of perforation or hemorrhagic changes because sometimes many changes are going to be immediately there. But also farther away. So what we do is we basically try to identify the more proximal aspect of the specimen in terms of the mesentery, so where the surgeon may have cut the mesenteric fat. Sometimes there's a little bit of cautery artifact that allows you to recognize that area and sample that portion, because over there is where you're going to see the bigger vessels actually. And as I said, some of these diseases may be present in the smaller size vessels, some are in the medium size vessels. So you want to sample those larger vessels that may be coming in the mesenteric fat. I think you initially starting, if you don't see any gross abnormality, for example, thrombosis or necrosis or hemorrhagic changes, starting with 1 or 2 sections of the mesenteric fat that includes some of these vessels that are grossly visible is a good start. Then I think I always correlate with the history to see if there was some other evidence of either systemic disease or concern for a primary vascular pathology. I will go and sample more. But starting with at least a couple of sections of the mesenteric fat with vessels is good. And obviously sample areas of hemorrhagic changes in the mesentery, thrombi that sometimes are visible, areas of fat necrosis, as well as some areas of normal mesentery. So not only just the areas with changes.
Thank you. The next question is from Zinat, and I think this question is asked by several others also, that how do you approach gastric antral vascular ectasia type of lesions? It seems that these are quite vaguely reported in practice, like a portal gastropathy versus GAVE. And do you have any specific approach regarding?
Regarding the sign out, I think many of these patients have a quite characteristic endoscopic picture that the clinicians know. So in our experience, many times they come as rule out GAVE because that's what they are thinking clinically, and they may have already the clinical picture as well. So what I think is quite challenging is sometimes the histologic evidence is quite subtle, and that's where the CD61 becomes a tool to use. I think if I find the thrombi and it's a reactive gastropathy picture in the right clinical setting, I have no problem with saying gastric antral vascular ectasia in the line diagnosis, because that's what it is. I think the problematic cases are those in which we may have histologic findings and sometimes not so commonly they don't see the endoscopic findings. And in those cases, I think it's fair to say reactive gastropathy with congested capillaries and rare fibrin thrombi is the comment, and in the comment say to raise the possibility that this is the case. But I think there needs to be a clinical correlate to that. So the way that we sign it out kind of depends. But more commonly, I would say that is the full-blown picture, the clinical and pathologic, probably more subtle, that we can say that this is GAVE.
Right. On the other extreme, suppose the endoscopy says that it looks like GAVE, and on biopsy you just see some dilated capillaries, and even after levels you don't see thrombi. How do you report that?
Yeah, we can only report what we see, right? So I'm probably going to be more descriptive in that case and say reactive gastropathy and put a comment saying that the classic features of GAVE are not seen. But many times it's sampling, right? It's not, we just can't name it just because we don't have the thrombi. So we'll probably go with a reactive gastropathy in that case and say that, this could be due to sampling.
The next question is from Minesh, who wants to know, what are your clues for identifying Behçet's disease on endoscopic biopsy?
That's a very difficult thing to do, I would say. Behçet's disease, we didn't talk about vasculitis. Vasculitis, I find it probably the most challenging topic among vascular. I wanted to include a case today, but I think it's something that it's very, very rare. In fact, I have looked at our own files, and it's very rare for 2 reasons. Not because they are so uncommon, but because most commonly the specimens, when they come out, they don't include the vessels that are typically involved in the most frequent vasculitis that we see. And sometimes the findings that we have are quite non-specific and they overlap between multiple things. So it's just a challenging diagnosis. But Behçet's in particular, I think it's in the differential of Crohn's disease many times, and it's well known. Behçet's disease will have oral lesions like Crohn's disease, but clinically they do have uveitis more frequently than Crohn's disease. So, and they don't have perianal disease like Crohn's will have. So those are clues that, you may be thinking of IBD, in particular Crohn's disease, but the picture is a little bit off. I think on a mucosal biopsy, I don't know how to tell them apart. That said, histologically, you can see involvement of veins and arterioles, while Crohn's disease is typically an arteritis. And this requires a full thickness view of the specimen, really. Granulomas are not typical of the sets, so I think there are many clues and clinical and histological that we can use on a resection specimen to favor, Behçet's disease versus Crohn's disease. But on a mucosal biopsy, I would say it's very, very, very difficult to differentiate sometimes any of these entities, because what happens is patients develop even ulcer. So they enter the differential of a non-specific ulcer or ischemic injury, but it's very difficult on mucosal biopsies because many of these entities don't have distinct features on the mucosal biopsy. So I would say it's more a diagnosis that you can do or you can make on a resection specimen.
One last question. This is from Khadija, who wants to know, how do you differentiate between ischemic colitis and pseudomembranous colitis?
Yeah, as I said, there's quite a bit of overlap. Pseudomembranous colitis due to C. diff infection tends to be more of a diffuse process clinically, while ischemic colitis, even with pseudomembranes, tends to be more of a localized segmental issue associated with the vascular distribution or vascular flow to that segment. As I mentioned before, having just the pseudomembranes on endoscopy is much more frequently associated with C. diff. But many times the clinical picture doesn't help you that much because these patients tend to be older, tend to be multiple medications, but they also have risk factors for ischemia. So the clinicians many times kind of struggle with the clinical picture and kind of in terms of differentiating these two from each other. Histologically, I would say that more typically hyalinization of the lamina propria, hemorrhagic changes, and wither crypts are more classic of ischemia, while pseudomembranous colitis can have particularly some reactive mucin loss and some wither crypts. It tends to be a much more inflammatory process, so much more of neutrophilic infiltrates with crypt abscesses, so much more solid neutrophilic inflammation because it's an infection at the end of the day. So in fact, the amount of inflammation is key versus hyalinization and lamina propria looking more pink and red in ischemia. I think it's something that can be helpful. That being said, there are going to be cases that we can't really tell them apart, and this is why we may sign out some of these cases as ischemic pattern of injury and provide a differential diagnosis. And the final say for those cases will be actually stool testing. So for the antigen, or depending on the methodology that they use, but it's not a very easy diagnosis. It's easy in the cases that are black or white and at the end of the spectrum, but there may be cases that overlap. Again, I cannot emphasize enough the correlation of the histologic findings with the clinical picture is critical, really, for any of these cases.
So no, thank you again, Dr. Allende, for this excellent lecture and covering this very difficult topic. And you would be happy to know that there were hundreds of viewers who had defied many time zones to stay awake. Maybe it is late in some places to listen to your lecture. Thanks to our viewers. And we had viewers as far as from Argentina, Singapore, Colombia, Tanzania, Bangladesh, to name a few countries. Thanks, viewers, for all your support. And please don't forget to follow our Facebook page as well as subscribe to the YouTube channel, that is Patcast. And also please subscribe to our newsletter so that you can stay updated with all the upcoming lectures. And the next lecture is on Tuesday. That would be a liver pathology lecture on July 21st, 8 a.m. Eastern Time. And Dr. Romil Saxena from Indiana University will talk about fatty liver disease. So hope to see you then. And thank you again, Dr. Allende, for this talk and time with us.
Thank you so much. It was my pleasure, and I'm glad you guys enjoyed it. So I'll see you next time. Have a good day, everyone.
Bye.